focused on cyclosporine, including its mechanism of action, clinical uses, and adverse effects. Question 1. Mechanism of action. A 42-year-old man is started on cyclosporine following a kidney transplant to prevent graft rejection. Which of the following best describes the mechanism of action of this drug? A. Inhibits dihydrofolate reductase, preventing DNA synthesis. B. Binds FKBP to inhibit mTOR and block IL-2 signal transduction. C. Binds cyclophilin and inhibits calcineurin, preventing IL-2 transcription. D. Blocks IL-1 receptor on T cells. E. Inhibits purine synthesis by blocking inosine monophosphate dehydrogenase. Correct answer, C. Binds cyclophilin and inhibits calcineurin, preventing IL-2 transcription. Explanation: cyclosporine is a calcineurin inhibitor that binds cyclophilin, leading to inhibition of calcineurin, which is necessary for activation of NFAT, nuclear factor of activated T cells. This results in IL-2 transcription and T cell activation. Why not the others? A. Describes methotrexate. B. Describes tacrolimus, not cyclosporine. D. Not the mechanism of cyclosporine. E. Describes mycophenolate mofetil. Question 2. Adverse effects. A 35-year-old woman receives cyclosporine for management of severe psoriasis. After several months of treatment, she presents with elevated serum creatinine and gingival overgrowth. Which of the following is the most likely cause of her renal dysfunction? A. Direct toxicity from cyclophilin binding. B. Immune complex-mediated glomerulonephritis. C. Renal artery thrombosis. D. Calcineurin inhibitor-induced vasoconstriction. E. Infection-induced pyelonephritis. Correct answer: calcineurin inhibitor-induced vasoconstriction. Explanation: nephrotoxicity from cyclosporine is due to renal vasoconstriction, leading to decreased renal perfusion and GFR. It is dose-dependent and especially common in patients with baseline renal impairment. Why not the others? A. Binding cyclophilin is part of its therapeutic mechanism, not the cause of nephrotoxicity. B. Immune complex GN is unrelated to cyclosporine. C. Thrombosis would present more acutely. No signs of infection are mentioned. Question 3. Clinical use and toxicity comparison. A 48-year-old man who underwent heart transplantation is receiving immunosuppressive therapy with cyclosporine. Which of the following best explains why his regimen must be carefully monitored? A. It has a narrow therapeutic window and is hepatotoxic at high doses. B. It causes irreversible nephropathy even at low doses. C. It increases T cell activity, leading to autoimmunity. D. It is highly nephrotoxic, especially at higher doses or in patients with renal impairment. E. It interferes with B-cell maturation and antibody class switching. Correct answer, D. It is highly nephrotoxic, especially at higher doses or in patients with renal impairment. Both cyclosporine and tacrolimus are nephrotoxic, especially in high doses or in patients with pre-existing renal dysfunction. Close monitoring of renal function and drug levels is required. Why not the others? A. Cyclosporine is more nephrotoxic than hepatotoxic. B. Nephropathy risk is dose-related, not irreversible at low doses. C. Cyclosporine suppresses, not increases T cell activity. Cyclosporine targets T cell activation, not B cell function.